recognizing that even though HIV/AIDS is in fact a treatable disease that people are now living for an extended period of time, it still remains an important cause of morbidity and mortality for individuals who are infected. What's really important then is to get an understanding of the life priorities and goals of care of this particular vulnerable subpopulation. And really now, less attention has been focused on really attending to older persons who are aging with HIV. So our overall study aims were to understand what they understood about the illness, how they perceived the illness as they were approaching the end of life, and explore what their life goals and care priorities were. We identified individuals who were approaching the end of life on the basis of clinical indicators. And ultimately the clinical indicators were one in which the treating physicians who were infectious disease specialists focusing in HIV/AIDS acknowledged that this would be an individual who they would not be surprised if they in fact died in the next 3 months. So it wasn't necessarily a diagnosis of you are terminally ill and imminently dying, but the likelihood of you surviving beyond that period is lower. What we wanted to be able to do is really understand the situation, the life situation and priorities in this particular population to improve patient-centered care and to really enhance communication and shared understanding of the dying individual's life preferences at this particular point and their care goals at this phase of the illness. So we're really looking at communication and relationships between the dying patients and their family or informal caregiver, and also enhancing communication between the patient, family, dyad, and the clinical care team. This study looked at all individuals who had this clinical diagnosis of having the advanced stage of AIDS. For this particular presentation, because of the fact that focus on older adults has not been a priority in the illness course until recent months, it was restricted for sub-analyses to look at those who were aged 50 and older. What we did is a mixed method study. What that means is that both the patients and who they identified as their informal caregiver completed in-depth interviews and a brief questionnaire. We abstracted information from the patient's medical records, and the in-depth interviews were audio taped and they were translated into English if they were, because they could also have been conducted in Spanish. Those were the two languages we used. Then they were transcribed and subjected to content analysis. We collected the data using bilingual English-Spanish health clinicians, and our population was almost evenly split between both men and women. The majority of them were in the 50 to 59 age range, although a substantial number were 60 and older. And the majority were Black, non-Hispanic, followed by Hispanic, with then the white, non-Hispanic, and other population being in the minority. This gives you a little bit of an idea of their sociodemographics related to relationships. 69% were widowed, divorced, or separated. 7% were currently married, and 24% were never married. 86% of them had one or more children. In terms of education, again, reflective of a range of background, we have not quite a third who were in high school, less than high school. The majority did have a high school degree, and about a quarter of them had some college degree, college education or a degree. In terms of where they were currently living at the time of the initial interview, most of them were in their own residence. That means, you know, an apartment, a housing complex of some type. A minority of them, just about a quarter of them, were in a variety of other residences. Very few were in the hospital at the time that we were interviewing them. And that would have been more of a long-term care facility rather than being in for an acute stay. Interestingly, only 10% of them were in housing for people who are living with AIDS, and there were about a subsample of just 3% who were in a welfare hotel or shelter, so they were virtually homeless. If we had looked at the broad range of the overall population that we did in fact survey, those numbers actually went up. So the older adult population who are dying from AIDS had a more secure housing complex situation for themselves than the younger adult one. In terms of what their current status is, not surprisingly, almost 80% of them were on disability. None of them were actively working, not surprisingly given the health condition they were in, and 7% were retired and 3% other. One of the things, before I go into our qualitative findings, is that we wanted to go and get some standardized measures. So the Memorial Sloan Kettering Assessment Scale, the MSAS, was developed for originally on cancer patients. And originally AIDS was only treated in cancer hospitals. Many of the symptoms and many of the etiology in terms of how you can kind of manage those symptoms and the safety precautions for the healthcare personnel were already routinely being done in cancer hospitals given the severity of different types of cancer conditions. So the symptom scale actually fits in very nicely with the range of issues that AIDS patients are experiencing. And what we see is that the main issue, the symptom that they're mentioning at the time of the interview, is pain. Not surprisingly, following that is numbness and tingling, dry mouth, shortness of breath, difficulty sleeping. Then we get into lack of energy, worrying, and problems with urination. What does that mean, though, for these individuals? You now have a profile of what their symptom assessment is. You know that they are in the last stages of life. You can have a little bit of an idea of what their life situation is. A standard illness-related quality of life measure, asking their assessment in the last 3 days, experienced activity living pain, at least limiting pain, at least a moderate amount of time. More than half of the sample said yes. Experienced other symptoms, a range of symptoms such as nausea, coughing, constipation for a moderate amount of time, 40% said yes. When you ask them about a existential approach to life, as how are they feeling from an emotional or spiritual perspective, 82% felt, despite these symptoms and despite their diagnosis, that life was worthwhile, all or most of the time. Almost 90% felt good about themselves as a person, all or most of the time. Virtually all of them said, it is important to me that my life has meaning. And another almost universal agreement, that it's important to me to be at peace with myself. So that gives you a little bit of an idea as to what we are moving towards in terms of what their life quality is. What is important to them is they have to feel meaning in their life. They have to feel at peace. The in-depth interviews allows us to get a better understanding of what are the important domains in their life and what is helping them experience these feelings. So family life is one of the areas that's important and meaningful. As you may recall from the earlier slides, the majority of the individuals had a history of marriage or were currently married, but many of them had children. So I love my little grandson. I like being around him. So I would like to be a good person and be happy with my life and my family and friends, that's all. So the grandchild is important. Again, someone else is saying, thinking about my life right now, the important things are my family, my relationship with my family. So here we're talking brothers, sisters, mother, children, grandchildren. So we're seeing people who are embedded in a social network, and that social network is meaningful to them. Someone is 50 and older, they still have elderly parents. I love my mother very much. What makes it life meaningful is like sometimes when we're watching TV and stuff together and we see a certain program or something that we both identify strongly with, we don't even have to say nothing, we just smile. So the idea is that family relationships, significant others in one's life, are both a source of strength and a source of a sense of peace and fulfillment. And these are individuals who, when you've seen from their socioeconomic background, you see from their advanced health status, you see from their symptoms, you wouldn't necessarily expect life quality. So digging deeper and finding out what are the things that, when it comes down to it, this is what's important, and this is what they have. What has the illness done in terms of how they think about life? So HIV/AIDS, it increases what's important to me in my life. It makes me know that you can conquer what you set out to do regardless of your illness. Here's someone else. Now, you don't see the person who's giving these quotes, but physical things, cars, bling, parties, popularity, have kind of dwindled in my life. It's important that people see me beyond my clothing and my things, and that I'd like to be more spiritual and more sound and more solid in my own beliefs. This is someone who is pretty much bedbound most of the time. And his existence is totally different than what it was earlier on, but what's important in his life he's had a transformation and focusing more on a internal, more spiritual, existential. So that's where we get into the idea of personal and transformative reflections that they're sharing with us. Having AIDS has given me the time to sit down and determine what's real in my life and what's important in my life. Here's a very simple thing, which may be very difficult to achieve, but I just want to live a nice, happy, normal life before I die. And then when you're stuck with something that could very well end your life or change it a lot, you start appreciating life much more. Here is, again, a very profound statement. It's important how you think, because what you think is who you are. I'm all spirit. My body's totally beat down. When doctors are standing over me and act like I'm not there, as they talk about death and its chances, I don't even pay attention to that anymore, because my spirit is beyond numbers. So if you're talking about person-centered care, there's a person there regardless of what you know about how they got to where they are, or what you think their capacity for understanding and a deep, profound meaning in life. It is very awe-inspiring and makes you kind of wonder what the quality of care can be for an individual to have them, despite all that they are going through and certainly existing, still end up having these strong feelings and emotions that they're just sharing in an interview. Social relationships are of value. My grandkids, okay? I can't wait to see them when they're growing up. And when they come, they wipe me out. It's beautiful. So family is still important in the visits, and those are the things, those are the events that they're living for. She's, my daughter, having a boy, she just found out. So she's got like another 4 or 5 months to go. And the baby will be here. So I hope to be around to see my grandchild. A very realistic hope. Will it happen in this particular case? We don't know, but that's what is driving someone to survive. That's what the meaning in life is about. Again, my family, being around them, just being there for them, talking to them. knowing that they're around when I need them, just being there. And, you know, not everybody has biological family, but they have people who they feel close to, and their family in every sense of the word. Friends, having people who care about you. Okay, sorry about the little heading there. The other thing that the diagnosis and the stages at this particular point may have motivated, change in who they are as a person. It's when we talk about life events that could be traumatic being transformative, so can a diagnosis of a disease like AIDS, especially the early AIDS epidemic. Many of them were people who really did have lifestyles that people would not necessarily regard as being respectable, histories of violence, a number of different types of things. The event and where they are now are things that have changed the population in meaningful ways. A statement like, what I want to do now is to give something back. Again, another one. Before I was like, it's all about me. Now it's all about everything but me. And it made me a better person. It made me look at life more seriously. It makes me take things more seriously, you know? I'm not, say, dependent on substance abuse or alcohol or cigarettes and all that. I stopped that ever since I got this disease, you know. Before, I didn't even think about it, but it just made me a better person, you know. So here is an example of how the disease event had again, positive change in people. They didn't change for the sake of saying, oh, well, if I do this, I'm going to be cured. They changed because they started saying, what am I doing? This is not meaningful. And changed in a different type of way. The transformative experience, they perceive it in those terms. My life is better than it's ever been. I'm weaker physically, but I'm stronger spiritually. HIV, made me a better person. It made me look at life more seriously. Again, I'm not, say, dependent on substance abuse or alcohol or cigarettes. I stopped ever since I got this disease. It just made me a better person. So life goals reflect what's meaningful to them. The earlier quotes talked about the importance of family and social relationships. And in fact, what is their goal at this particular point in their life? Well, just staying alive and taking care of my family. Just to take care of my grandchildren in case my children can't, that I be there for them. So we're not talking about someone doing something for them, they're giving back. And their role in life at this particular point is to try to give back as much as possible. Another source of strength, in addition to the spiritual relationship, the social relationships are a resurgence or a development of spiritual values. So my spiritual upliftings give me a little more sense of like strength. It strengthens my soul and in return my spirit. And then someone else talks about the family as being their source of strength. So as long as I have my family and me myself being strong and knowing that I can live my life on life terms and taking one day at a time, that's my goal. It's live as though there's nothing wrong. It doesn't mean with all this going on that we're talking about complete denial. That is like, you know, oh, everything is great, I'm now a better person, I'm going to just keep moving along. There is also a reality check that they do reflect on and accept. So I have neuropathy. So I have, if you remember the symptom list with all the number of symptoms they had, so I have, like you say, a lot of pain. So much so, some days it's not good. But it doesn't like bother me, you know. It's just a part of my life. And that's the way it comes. So there's a recognition and an acceptance. But in addition to that, there's an appreciation that is now coming out of the specialness of being able to still be alive. So every day is a blessing, you know. I have been near death so many times that I have respect for life now. And what? I have pains. I don't get stressed out about it. You know, I have to deal with it. So this is powerful, a very powerful, eye-opening statement for anyone who is involved in either clinical care or supportive counseling. You don't really, having seen the sociodemographics of the epidemic, of who this sample is, what we're seeing here is an extremely inspiring and profound sharing. I deal with my symptoms. I deal with the symptoms. I deal with the fact that I can't walk fast. Most of my friends, those pictures that you see around here, the interviewer was interviewing them in their home, are passed away. So I feel very lucky. The other thing is, these are the individuals who are 50 and older. So everybody who is aging starts thinking about life as an older person. And there's recognition here that not only do they have AIDS, but they also are older. I can't say my life will stay the same. Let's say this, my mental health will stay the same, okay? But the body was only made to last so many years. And then I'm still here, so I still have time. You know, age is just, you are as old as you feel. Yeah, I be in a lot of pain. I deal with a lot of things, but I can deal through this because I'm still here. So there's this essential life spirit that is just carrying people forward despite what someone as a objective observer might say, why, how? This seems like an absolutely horrible situation. Again, think back to just that list of symptoms. The majority of them have anywhere from 2 to 5 symptoms constantly in their lives. And with that, they still are finding meaning in life. They're not just talking about fear and wanting to hang on, they're talking about meaningful experiences. They do recognize that AIDS at the stage that they're at in their condition is in fact a terminal illness, and so they do acknowledge that. Being HIV, it shows how fallible, and what's the word? The mortality is there. You feel invincible, you do. That's a common thing. None of us want to think about dying. We all assume we're ideally somehow magically going to live forever. With a diagnosis, it does change though how you perceive what you can do with your life and where your lifespan is. So the recognition here is that it's a day-to-day thing. It's only taking one day at a time. That's all life is, one day at a time. But life doesn't stop. You know, you just keep on living. You know, and when it's your time, it's your time. So it talks about the fact that we're all mortal. It talks about the fact that don't keep worrying about the future and fretting about how much time you have left. Live for the moment. That's all we can do at any one particular point in time. And just keep on living until you don't, is the overall conclusion. And then the actual dying part. I'd love to go to sleep and not wake up. That's everybody's wish, you know. In other words, not be aware of impending death. I'm not scared to die. I never was. And I learned young that dying is a part of life. Again, a hint into this population's background. And I've dealt with death all my life, since my mother died when I was 10. Life support is a situation that many people who are providing health care may be needing to deal with their patients from time to time. the question they asked me was, do you want any machinery to keep you alive? And I said, please keep me alive. We have a phrase in recovery. For those who are not familiar, we're talking about alcohol or drug rehabilitation. Don't leave until the miracle happens. And I would hate to tell them to cut the machine off on Wednesday and the cure come out on Thursday. I'd just be the laughing stock of heaven. So this idea of take life one day at a time, live life to the fullest to your capacity, and don't worry about the things that are out of your control, and ultimately be true to who you are and what's important to you in your life. So living life to the fullest. Every day has a certain amount of challenge to it, and I hate to refer to myself as sick, but I use the term physically challenged because there's not a day that goes by that I'm not challenged. But each day I meet that challenge. I've managed to slow my pace down, and I understand that I can't do many things that I used to do. But I try to focus on the things that I can still do than the things that I can't do. There's so much left for me to do, and that my challenge now to sit down and realistically come up with a concrete plan with how much of you is left instead of how much of you is lost. Again, these are words that need to be heard and recognized and acted on. So, in terms of what we are covering, then, in terms of the summary and concluding thoughts from this particular set of, to me, very provocative quotes, is that living with HIV/AIDS presents unique psychosocial problems for patients and their families. We are aware of that. But the other thing to kind of recognize is that age is really irrelevant in general when we're talking about living life and approaching death. Because here's an example of individuals who, on the basis of both their age and their status with the condition, because they were part of the earlier cohort of folks who developed the disease before all the marvelous medical advances have made it more of a chronic disease rather than a acute condition. It raises the complex issues, though, of premature death, as any serious illness does, and unfinished business and legacy. I think those are really important concepts to keep in mind, that regardless of who you are facing and treating with illnesses, especially an illness that someone may have gotten through very antisocial social behavior or illegal behavior such as drug users and abusers, these are still individuals who have the capacity and are, in many cases, moving to a stage of dealing with a number of complex issues as they are approaching the end of life, and dealing with unfinished business of their lives. In many cases, that unfinished business is either preparing others to not follow them in their path, or to be able to give back to their family at a time when previously they may have been too self-centered to not give them the attention and care that they needed. And then ultimately the legacy. Everyone does not want to be forgotten when they die. They want to leave their mark on the world in some way. Ideally, we want it to be in a positive way, not a negative way, but the idea of legacy is there. And the ability to facilitate people's giving back in a way that is meaningful to them is very important in coping and helping these individuals through the final stages of life. So HIV/AIDS then really precipitates a summative life review. It's characterized by reflecting on their lifelong behaviors, which are colorful, to say the least, for a number of folks, reaffirming some of their behavior, and providing insights and the opportunity to address those behaviors that they regret. The findings also support the value of integrating palliative care early with active treatment. So we now refer to it more as a palliative approach rather than palliative care, because of the idea of thinking of palliative care as only something at a point at which people are eminently dying. But the idea of palliative approach is really the idea of facilitating and maximizing people's ability to live fully with their condition. Even though the care that is being given is not curative, it's managing. So that's where the idea of palliation of symptoms comes into play, as opposed to talking about it as all we can do at the end of life is just take care of symptoms. What we can see is that we can manage symptoms earlier on as a way of helping to enhance quality of life, even if you can't eliminate them and find a cure. So findings, palliative care emphasizes, in addition to the clinical care that one might be thinking of, it emphasizes the importance of communication, of collaboration, and of willingness to accept patient-focused outcomes as being paramount. So the idea of communication is patient and family and significant other communication with each other, so that family members understand exactly, this is not the same person that we knew 5 years ago. He always was a troublemaker. Is this really, do we take him seriously when he's talking about these things? Yes, that's what this study is showing, is that this illness does in fact change people in meaningful ways, and it is really an opportunity to kind of reunite broken families and mend relationships, and perhaps provide a meaningful legacy for the survivors. The idea of collaboration and willingness is the idea of, like, what's the role of the clinician in this? Well, the role of the clinician is to understand and honor the patient's wishes around care decisions. And that means being on a respirator or not, do not resuscitate orders, having a medication that might prolong life, but prolong life in a state that they can't do what they want to do at that particular point in time in life. And so it may be against, a good clinical care practice as a first thought, but it's something that is in line with what are the patient's priorities and life goals at that time. So quality of life and decisions impacting care really do require this continuous person-centered dialogue. And that's not easy. That's not easy for clinicians, and I don't have in this particular presentation the perspectives of the family and significant others, but we interviewed them as well too. And what we do see is that there is also, it challenges them as well in terms of being able to negotiate this very complex trajectory as patients are approaching the end of life. So when we're talking about patient centered care and patient-centered outcomes, we really are talking about like a triangle of relationships. So we have the medical or healthcare providers, the social service providers as like the official approach. We have the patient, and then we have the broad informal support system, and many times we don't really, if you think it's difficult for two of those things to be in sync, try getting all three. It usually requires quite an effort. So that is the overall presentation of what I want to focus on today in terms of giving you some insights into how the life priorities of the older population is as people are approaching the end of life. With a disease that in the early years was not really regarded as one that one would be talking about as socially accepted. Some of the early AIDS cases that we had were not in this study, but just in general. At the time, I was at Sloan Kettering Cancer Center, and people would just be coming in and dying within a few months. And so what was interesting is when you looked in terms of risk factors, what were a major source of infection for many of the cases were blood transfusions. Because this is before we understood about the blood testing. And what happened is that we had families who were not only traumatized over the fact that a loved one was dying, but that individual was dying from a disease that implied a social background that was not appropriate for them. So we had family members saying that, you know, not only was it very difficult for us to have lost this person, but we had to go and describe their disease and their death and hide the fact that it was AIDS. So we would have like an 80-year-old grandmother who died following a blood transfusion that she received when she was in a car accident. A young family in which the husband died and they had several children, and the wife kept saying, no, he wasn't gay, he wasn't bisexual, he wasn't a drug user, he had a blood transfusion. But obituaries would not be able to go and say that. The close family members were not told what it was. So AIDS has always, I see it as really challenging the healthcare profession to change, to bring in the person in the social context above and beyond the biology, and to make it much more the patient-centered care, person-centered care probably came out of many of these types of events, because the early AIDS docs are still involved in providing HIV/AIDS care 40 years, 30 years later. They're the leaders in the palliative care movement now. And the idea of being able to become humanized by who you care for is, I think, a very important issue. If you can get positive benefits out of horrific events, these are the types of events that we need to kind of recognize. And for that reason, I tend to give very depressing talks, but it's something that I feel is very important to another dimension to bring in as one is talking about preparing like the next generation of healthcare providers. So at this point, comments, questions? We still have a few minutes. Yeah.
I have a comment. Thanks for presenting this. A comment and a question. A comment you sort of alluded to is that this is an interesting group because if my math is correct, this is a group of people who are likely infected prior to ART. So in a way, it's sort of a survivor cohort, and if we just wait 20 more years, it'll be a much different group in terms of their experience of surviving and aging with HIV. But what's striking to me is, as I was reading, you know, the quotes that you were presenting, I was trying to figure out if there's a way that would in fact differentiate this group from a group of people who were dying from something else, or who were dying from similar conditions. I don't know what their causes of death would be, but were not HIV infected. And I mean, the goal is, I think, in any disease, but especially in HIV, is to have people live and die just like everybody else, which sort of feels like the quotes reflect that. I don't know if there's something.
Well, I mean, I've also done cancer research and qualitative. To me, the qualitative piece is the important. Instead of pigeonholing everybody, the qualitative allows you to have the person define themselves.
Right.
And the difference is the stigmatized aspect of how this disease, how they got infected with the disease. Right. And because of that, that has a little bit of one, either in cancer years ago, and still in some cultures, is a stigmatized condition. It implies that you did something wrong. You know, obviously, you get lung cancer, and it's like, oh, well, you were a smoker, you should have known better. It's like that type of thing, and that's not the situation. But I think what AIDS has done is it's really transformed healthcare and introduced some very important necessary changes to not only humanize it, but it made some very important biological treatment changes as well too. But it's something that I think that, you know, the world has coalesced around in ways that they have not done all the other types. Right now, I'm starting to see a little bit of that as we're talking about Alzheimer's and dementia, because of the fact of the aging population. There's just so many more people like that, and it takes like a substantial, there has to be some sort of major risk or impact to start changing the system and start turning it on its head and looking at it a little bit differently. So I think there's similarities that we can look at across different diseases, but then there are some unique differences as well too. And it's useful to see what we could take from one and apply it to another, but then also recognize that elements may not be a one-on-one fit.